أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم.
وأيوب إذ نادى ربه أني مسني الضر وأنت أرحم الراحمين فاستجبنا له فكشفنا ما به من ضر وآتيناه أهله ومثلهم معهم رحمة من عندنا وذكرى للعابدين وإسماعيل وإدريس وذا الكفل كل من الصابرين وأدخلناهم في رحمتنا إنهم من الصالحين وذا النون إذ ذهب مغاضبا فظن أن لن نقدر عليه فنادى في الظلمات أن لا إله إلا أنت سبحانك إني كنت من الظالمين فاستجبنا له ونجيناه من الغم وكذلك ننجي المؤمنين وزكريا إذ نادى ربه رب لا تذرني فردا وأنت خير الوارثين فاستجبنا له ووهبنا له يحيى وأصلحنا له زوجه إنهم كانوا يسارعون في الخيرات ويدعوننا رغبا ورهبا وكانوا لنا خاشعين.
Dr. Umer, Dr. Yasir, Dr. Kazim, Dr. Masood. So, and I'm really thankful, Professor Julio. It must be very early morning and cold there. So I think it's almost 6:30 a.m. in Canada. So we are ending the day here. They are starting the day. That's how the world goes on. So let's start with our webinar. So this is the webinar number 29 of the Pre-Orthocon webinar series. And Professor Julio has a very vast experience in sports medicine. He has more than 100 publications and more than 100 talks in his profile, and a very research-oriented career. So this webinar we have tried to cover the relatively unusual topics, a graft which is less commonly used, and then few other topics which are answering the most important questions: alignment issues, ACL with meniscus issues, ACL in children, and ACL with ALL and other augmentation. And we tried to avoid discussing more common issues which everybody knows. So as I was saying, so we'll switch to Professor Fernandas for his talks.
Thank you, Naveed. Thank you, Umer. Thank you all for inviting me over. And just let me know if the sound is not correct, and I'll check. And salam alaikum to all the participants of this meeting. I was wishing to be live and with you personally. We discussed with Umer last year to be there, so hopefully we'll get together and be in person, just shaking hands all over the place. I'll talk about. I'm just get my screen there, and let me know if it's showing. Is it showing? Can you see it? Good. So I'm just going to talk about an interesting concept on quad tendon as a graft. I decided to do it as a demonstration too, so people that are not familiar with that can take a look and see what it is. So, and then at the end we'll discuss some concepts and some results. So, with no further delay, I have nothing to disclose for this presentation. Just to talk about Canada and Montreal a little bit, our program here at the University of Montreal is the largest and the oldest program in orthopedic surgery in Canada, for those that don't know that. We've had a merge here a couple of years ago, so actually we're working on 18 surgeons, which is a lot for Canada, by the way. I know that you have more people in our teams than we have. And we also take care of the Formula One Grand Prix every year. It's been 25 years that we're in charge of that. So you're welcome to come, and then we have a fellowship program. And anytime you have people willing to come, talk to Umer and the other folks at your programs, and we'll definitely have a collaboration on that. My preferred technique is an all-inside technique for primary ACLs. I think people are familiar with that, but actually, generally, a single bundle anatomic reconstruction with retro drilling. Nowadays, we have plenty of companies that offer the hardware to do this, and it can be done with any choice of graft, as you can see here. So I'm going to explain basically the graft choice and show a little bit of this all-inside technique for you. Let's get a case, a 20-year-old woman. Which she works in the hospital, by the way. So with the pivot trauma, instability. Clinically, she was hyperlax also, so there's going to be a discussion on the interlateral ligaments later on. So it's going to be interesting to superpose these talks. An X-ray that's fairly common, no big deal there, stellar height and everything. And then you can see here you have a high-grade proximal complete ACL tear, a little bit of bone edema in this case. So typical case, young person, very active. And so what is this technique of quad tendon? You go after the middle third of the quadricep. So this is a view of the quad tendon. To your right, you have the vastus medialis. That's me operating. Sorry for that. And actually, you take the middle third of it. It's a thick tendon. I mean, it's a 10 millimeter wide and almost 8 millimeters thick. So you can use double blades, or you can use just a regular blade, and just make sure you have this 10 millimeter wide graft. Incisions are 2-3 centimeters usually, and as you can see, it can be done with a regular hardware provided by the companies with whom you work, or your regular scalpel. Once you get that, you can have a full thickness or partial thickness graft. So let's get this and take a look at what it is. So as you can see, you can have a thicker graft. Actually, it's thicker than the patellar tendon graft that you're used to work with. Full thickness or partial thickness doesn't make any difference as far as results or complications locally. It depends on the graft you want. Usually, you want a graft that's between at least an 8, ideally a 9 millimeter. And once you have that, I mean, just go and cut it off. It can be done with this cigar cutter, or it can be done with a regular scalpel. And as you can see at the end of this, you end up with a fairly nice graft. You'll have some more images now. So it takes around 5 to 7 minutes to get this graft out. You can have it with or without the bone plug from the patella. So if you're working with an all-inside approach, a shorter graft, 6 centimeters is enough. But if you want to have an open tunnel, you can have a graft that's longer than this. Is a 9.5 with a little bit of bone. You can have a smaller one if you need to. And at the end, this is what you see. I mean, once you're done with the graft, the donor site, if it's a partial thickness, don't even have to close it. If it's a full thickness, you can have some stitches on the paratendon because when you start your arthroscopy, you have a lot of fluid coming out of it. So this is basically it. And you see, you have a really nice graft, and for whatever technique you have, you like to use to prepare it. And then femoral tunnels are fairly straightforward now. I mean, we like to go into the 9 o'clock or 3 o'clock position for the anatomical reconstruction. Once again, as I said, retro drilling is available in almost all companies now. So you take the color of that you would like to see, but basically you position your guide on anatomical position. This is the lateral condyle. So you see where that's a 9 millimeter drill. You drill from outside in, and then you flip. And once you flip, you can see that you're drilling in the tunnel. You still have your cortical bone on the side. We're going. The camera is in the anteromedial portal, so actually you're looking straight into the tunnel on the lateral side. So this is what you see with the tunnel. So it's fairly neat. You have your suture passed on that to pull the graft into the tunnel later on. So tibial tunnels are straightforward too. I mean, usually 60 to 65 degree angle, a little anterior compared to what we used to do in the past. So you see, it's more of an anatomical positioning of the graft. So going anterolateral on this graft. Once you have that done, I mean, flip your retro drill your tunnel, and once you have your tunnel done, just pass a suture passer and bring it into the anteromedial portal. I used to take one at a time. Now I take both suture passers together, so I'm avoiding a double passer and soft tissue bridging on this. And you take a look at the graft now. I mean, I'm just going with the button all the way up on a retrograde fashion into the femur. So there's not a tunnel, but instead of a socket. So you pass it up, you flip the button, and these buttons are dynamic, so you can easily bring them to the cortical. So when you do the same thing on the tibial side, so you go anterograde on the tibial side, bring it all to the position, flip the button, and then you can tension. Once you tension, you can go for cycling. And the good thing about this kinds of buttons that they are very dynamic. You can cycle, and if you have a lax, you can always retension the system. So at the very end, when you're finished with the cycling and the retention, you have a very stable graft. And you can see these are two different cases with the quad tendon graft in position. So there's no impingement anterolateral, full extension, full flexion, and the graft looks really solid. So it's really an interesting graft for this procedure. I had a chance to take a look with the meniscal lesion to go back in one of the cases. I took some pictures. As you can see, you have good synovium around the graft. Graft looks very healthy on the image, and I think we can see how impressive these grafts become. Actually, a good graft will actually should look like that, whatever graft that you're used to work with. Just to give you an idea of what's going on now, in 2019, 2020, we have had a handful of papers on this technique and on this particular graft, and most of them have demonstrated that this quad tendon autograft is as good as, at least as good as, if not better than the patellar tendon bone BTB graft, and fairly better than the hamstring graft. So I know it's hard for you to see, but these are all good papers being published on the subject. So the graft seems to hold its ground. There's been one paper on the Danish knee ligament registry published in July this year that have had some bad results as far as revision rates for quadriceps tendon. So they had a 1.5% with patellar tendon, 2.3% with hamstrings, and 4.7% with quadriceps tendon. But if you look at the numbers of this registry, I mean, 500 quadriceps tendon, 14,000 hamstrings, and even almost 2,000 patellar tendon. So there's been a discussion on the paper, just discussing these numbers, and probably we have a type 2 error here. We don't have enough quad tendon here to be able to compare to the massive numbers of other graphs. But keep that in mind to have a balanced view on this. But if you go for all the systematic revisions and meta-analysis on this graph since last year, and actually what you're going to see is that it compares favorably with patellar tendon graphs and the hamstring tendon graphs. So I think questions for 2020. I mean, you know what? When I give this talk, I mean, the same questions I can recycle from my 2015 talks, 2011, 2007, 2013. We still discuss the same questions, right? So there's probably not one single good answer for the surgeon that's listening to us right now. I mean, it all depends on age, gender, sports, what to do best. I mean, if you take your pick, I mean, if you do it right, I think it should be all right. Allograft and autograft is another discussion that we can start later in another setup. I think the diameter of the graft makes sense. I mean, if you look at revision rates for grafts that are smaller than 7.5 millimeter in diameter, the revision rates are as high as 16%. 16% for you guys, it's 1 in every 6 patients that you do surgery on. So
Julio, can I interrupt you for a second? Will it be possible if we leave this hot topic for the discussion part, or you think you want? Because we have a lot of questions to throw on you, and that's the reason I thought this is such an informative info. We will use it to discuss and cross-question each other.
Listen, my pleasure. Then I can finish my coffee while you guys talk. So that's it. And don't forget, CCOT World Congress in Orthopedics. It's been postponed to Budapest next year, 15th to 18th September. It's going to be a hybrid one. We're going to have a presence for training and cadaver labs, but also virtual panels just like this one. So I'll stop there. Thank you for listening, and I'm going to be listening to my colleagues in Pakistan now. Thank you.
Thank you, Professor Fernandas. So obviously the main question which was coming in my mind was again the same related with the Danish registry, which you already explained. And obviously we will come to it again in discussion. So we'll continue with our talks. So I will again request our faculty to stay within 8 to 10 minutes. So we should have enough time for our discussion before our senior faculty leaves. So we'll continue with the adult ACL topics. So my talk on pediatric will be, I will do in the end. So Dr. Kazim, so we are coming to you. Dr. Kazim Najjad is our consultant orthopedic surgeon in Liaquat National Hospital. He was trained there, and then he did his sports fellowship from Iran. So he is very keen in educating undergraduate and postgraduate trainees, and very active in different POA forums. And to you, Dr. Kazim.
Okay, Bismillahirrahmanirrahim. First of all, thank you very much for the moderator for inviting me and giving me this talk. Today, I will going to discuss about the ACL with ALL is suitable for all reconstruction in ACL reconstruction. So I'm going to take you to the different aspects, starting from the introduction, history, anatomy, how we can see the MRI, and of course, the literature review, and what I do for augmentation, and last, the take-home message. So starting about the ALL, this new ligament was first announced by BBC News in 7 November 2013, in which they said they have discovered a new ligament in the knee joint by Belgium scientists, and according to them, it could protect it in the twisting or change direction of the knee. So these are the scientists who had discovered this anterolateral ligament. So, but when we review and see in the past, what we can find out in 1879, it was a Paul Segond who was the firstly described this anterolateral aspect of the knee, this ligament. According to him, it was a fibrous band. And now even we are very much familiar about this Segond fracture. This is basically the avulsion fracture that we deal with it. And as this was his paper, and according to him, he said a fibrous Pearly band showing extreme amount of tension during forced internal rotation. So this is how this Segond fracture looked like on cadaver, on MRI. So moving forward, it was his paper in the Journal of Anatomy, in which he described about the anatomy of the anterolateral ligament of the knee, and according to him, he showed its biomechanics. It has a lot of impact about the control of internal tibia rotation, and thus affect the pivot shift phenomena. So if we see this ligament, so this is where at the femoral attachment it is around, it is present on the posterior superior to the fibular collateral ligament, around 4 millimeter posterior superior, and it's go down and it is inserted between the this Gerdy's tubercle and the fibula in midway, or you can say 20 millimeter from the Gerdy's tubercle. This is the distance where it is, and 1 centimeter below the joint line. This is the exact anatomy of this ligament. So this was his award-winning paper in Isakos 2013, in which they shows this is basically a avulsion fracture of the ligament of anterolateral ligament, which they demonstrated, and which is being called as a Segond fracture. So it was a new discovery about this ligament, and they showed about this aspect of this ligament. What about on MRI? How we can see it? On MRI, if you can see, if it is very one can appreciate on the coronal cut, and it's have the femoral attachment, and then it attach on the ligament and go into the tibia attachment. Over it, there's the iliotibial band. It is coming below to its attachment. So this is on the cadaveric section. You can well appreciate it on MRI. And this coronal section, you can well appreciate it. It is an intact ALL, and this how it look like when there's a femoral lesion, proximal level. This how you can appreciate over here. And then when there's a tibial lesion, this how it look like. So moving forward, even in ISACO 2013 and AAOS 2013, they have in their paper discuss about the biomechanics. And this shows it has a great role in when the knee is between 30 to 90 degree. What at that time have very helpful resistance of the internal rotation of the knee, stabilize the knee in 30 to 90 degree. When the section ALL, it causes grade 1 pivot shift. When they section the ACL, it had grade 1 pivot shift. When the ruptured ALL were there, and with ACL, it is where the grade 3 pivot shift were ever been appreciated. So we know about the indication. What indication is when the ALL need to be reconstructed with the ACL, and this indication with high grade pivot shift, grade 3 degree on clinical exam, high risk athletes, professional soccer, basketball player, hyperlaxity syndrome patient, and associated Segond fracture. This is avulsion fracture of the ligament. And in revision ACL reconstruction, we have to augment with ALL. So these are the few of the method for ALL reconstruction. It is being well established by the authors about how it can be ALL can be reconstructed. This is a diagrammatic presentation how the ACL is placed, about the LCL and ALL where its anatomic landmark is, and on the X-ray laterally you can well appreciate about the ALL reconstruction. Some people they have this ALL reconstruction with the help of a fiber tape and with the knotless suture. They place it, and this how they this reconstruction ALL. And there is a few other technique which is well established about the ACL at the same ligament. They also make a ALL ligament, and this is the whole of the technique which is being presented in the literature. This is some diagrammatic presentation about it. So moving forward, literature review. Does every ACL need ALL? This is the question that we have to get the answer. This is a beautiful paper by the American Journal of Sports Surgery, Sport Medicine, and it was a randomized clinical trial. And it says that ALL reconstruction should not be performed routinely for patient undergoing ACL reconstruction. So it is been in this paper about the every ACL doesn't require an ALL prerequisite of the indication that has been mentioned before. There is another paper in which revision ACL reconstruction with ALL has been demonstrated that ACL with revision ACL with combined ALL reconstruction significantly reduce rotational laxity and shows a higher rate of return to the same level of sports. So there was a one paper, paper they have studied on the cadavers, and this shows adding an ALL lesion in an ACL deficiency knee did not increase tibiofemoral instability in this cadaveric model. So however, further multi-center trial is being required to establish this fact. So there is other modality in which there's a other technique how we can have augment in the ALL deficient knee. So how I do it? I do it by the extra-articular lateral ITB tenodesis. This is my landmark where I place, and I take this ITB of around 8 centimeter length, and then I move it over the LCL, fibular collateral ligament, and then this is the final how it's going to look like clinically, and then on the X-rays, this is how I do it in those who has a chronic ACL deficiency with pivot shift more than 3 degree. So these are the another meta-analysis about the extra-articular tenodesis, in which it has been shown in primary ACL revision there's no evidence which shows there's a benefit of lateral extra-articular tenodesis in reducing post-operative pivot shift. However, there is strong evidence of the combination of anterior cruciate ligament reconstruction with LET in those deficient, chronic deficient knee or with pivot shift more than 3 degree. There's another paper, American Journal of Sports Medicine, which has the same impact about the ACL reconstruction with the extra-articular iliotibial band tenodesis. So take-home message over here, ACL and ALL reconstruction not recommended in all knees. Whereas focus need to be back on extra-articular stabilizer for chronic deficient or revision anterior cruciate ligament reconstruction knee. Thank you very much.
Thank you very much, Dr. Kazim. So obviously this provides us answer with a very important question. So we are short of time, moving to our next presentation. So I will invite Dr. Masood Umer to for his talk. So Dr. Masood Umer, a section head of the orthopedic department at Khan University Hospital, where I am working, where we are hosting this webinar. And Dr. Masood has a very vast experience in sports, especially knee surgeries. And it may not be wrong to say that my initial skills for arthroscopy developed after assisting him in his surgeries. So I'm basically his trainee. So Dr. Masood Umer.
Assalamu alaikum. Bismillahir Rahmanir Rahim. Thank you for preparing such a nice webinar, Dr. Naveed and actually Dr. Umer Butt Saab. Let's move on. My topic is relatively simple. Repair with ACL tibial avulsion. And the injury to ACL, as mentioned before, is very common. more than 200,000 reconstructions being done per year, and more than 500 in USA and more than 400,000 worldwide. Tibial eminence fractures are not common injuries. The ACL tibial avulsion fractures are relatively uncommon injuries. Incidence is very low. Of all the ACLs you would see, maximally they would contribute about 5% of all the injuries we see in our clinical practice. And more so they're common in adolescents and the younger adult population. History goes back to 1875 when Ponsett first described it as an avulsion fracture of ACL from its attachment. And when I say pediatric or young adults, they are most commonly affected primarily because of the weakness of subchondral bone, which causes the bone to fail before the ACL fails, hence causing a fracture rather than a rupture. The most common mechanism of injury when kids falls and bicycle is a very common entity, becoming very common in Karachi also nowadays, especially in the background of the pandemic and lockdown. Tibial eminence is the non-articular confluence between medial and lateral tibial plateaus. It consists of medial and lateral tibial intercondylar spines and anterior and posterior recesses. It serves as an attachment for ACL and anterior roots of menisci. So it's important for us to understand the anatomy of tibial spines, which is shown diagrammatically here. The two spines in dark gray. As I said, most common age is 8 to 14 years. 40% of the time there are other injuries which we need to handle. They may be either meniscal or other ligamentous injuries. So it's important to be aware of them. This is an example where the tibial eminence got fractured, pulled, and then we got an interposed intermeniscal ligament under the tibial plateau or tibial spine fracture. So that would be a strong indication for surgery. Anyway, it is displaced, so we would rather go in, remove the ligament from underneath and put the bone fragment back. Myers classified into classically 1, 2, and 3, where 1 was undisplaced, 2 partial, and 3 as a displaced fracture. And then somebody added 3B, which was a displacement with rotation, as is shown on the first picture on the right. And then Zarinage added a type 4, where it would be comminuted. So as the tibial spine is the site of anterior cruciate ligament attachment, tibial spine avulsion may be associated with sometimes a tear also. And also, as I said, concomitant collateral ligament or meniscal injury must be looked for. Usually, again, a history of fall, twists, patient coming with a painfully swollen knee. And you need to do a straight plane X-ray, and that gives you the answer. As is shown here, a lot of times, as is shown here, the pediatric patient, there may be thin wafer of bone with a lot of cartilage associated with the spine. On the X-ray, it may look very thin. Actually, it's a big fragment. MRI is usually the investigation of choice, would also tell you, will also give you a lot of other information. And it would show you entrapment of intermeniscal ligament, as I said, and other concomitant injuries, as is shown in this diagram, is this imaging of the MRI, where the avulsion. I hardly do a CT scan for this, but people do it for more delineation of the fragment and its comminution. Now, restoration of the continuity of ACL is the major goal, and elimination of any mechanical block caused by the fragments, and restoration of congruity of the tibial plateau. And obviously, secondary goals would be the management of concomitant ligamentous or meniscal injuries. So type 1, we usually treat non-operative, which is a very undisplaced, just a crack in a cylinder cast or an immobilizer. Then it can be debated whether you immobilize in full extension or in 20 degrees of flexion. Obviously, you should consider drainage of hemarthrosis. Usually need immobilize for about 6 weeks in young kids, and then you do gradual transition to weight bearing and gradually increasing range of motion. Type 2 is a bit controversial where it is partially displaced. It usually maintains some contact. It's displaced from the front, usually in contact behind. It may still heal, but in a deformed position and would lead to a lax ligament if we treat it conservatively. So people have published close reduction of this fragment in 26 or 49 patients in this series with type 2 fractures. Most of the fractures are irreducible due to soft tissue entrapment. Now, type 3 and 4, obviously, strong indication for operative reduction and internal fixation, and the treatment of choice is arthroscopic fixation, arthroscopic reduction, and internal fixation. Now, we can use sutures, we can use metal screws, use bioabsorbable nails, K-wires, suture anchors. Obviously, we in our setup are limited by our resources, and we have to work and deal accordingly with patients according to their, which is unfortunate financial status, and can't offer a block treatment to all patients. So we have to innovate, and innovate in such a manner it's not very costly for the patient, and the job is done well at the same time. I'll come back to that, but this is simple procedures for our resident participants. You go in, you do visualize the fragment, you palpate the fragment. Usually the ACL is completely intact. You lift the fragment up, the picture on the right, you debride that crater, you remove the old clots and or any fibrous tissue. I've done it as late as a couple of years post injury where the patient could not get the treatment. So a lot of fibrous tissue can be present there. So you need to nibble that off or chew that up. And then you use a shuttle instrument, a suture lasso. And then there are various techniques described for passing this suture lasso. You can use a tape or a fiber wire. Whatever is available and can be afforded by the patient. And then the tibial ACL guide is inserted, 2 guide wires are drilled transtibially at the anteromedial and anterolateral margins of the fracture. There are techniques prescribed in which you can go through the fragment also and bring the sutures out through the fragment or through the anteromedial and anterolateral corners also. And use a 4 millimeter cannulated drill. Suture lasso is passed as is shown here, and then you bring them out as shown in the picture on the bottom. And you tie them at the anteromedial aspect of the proximal tibia. Now, as I said, larger tibial eminence fragments, especially which are non-comminuted but may be displaced, you can use screws. And this is the method I commonly use for fractures, in which it may be broken into 2, then we have to fix either of these fragments separately, but usually it's a single fragment. If it's non-comminuted, you can reduce arthroscopically and do a retrograde screw fixation as is shown here. Other methods obviously have been used by people for arthroscopic fixation. These are just book pictures to show. Just in the end, I would present a case of a young boy who presented to our emergency with this injury, tibial avulsion. CT scan had already been done before I could see the patients, and showing CT scan. But if you were to ask me, we can discuss. No big time need of a CT scan in addition to an MRI, which is already done. So we went in, cleaned the defect, and then this is how I do it: transfix the fragment with wires. And at the same time, if you are able to see, with a pointed probe, I'm pressing the fragment down. That means reducing it. And one of my residents is holding the reduction. I'm holding the scope. And then the wires are drilled into the fragment. They are checked both on an AP and a lateral view. Obviously, you need C-arm for this technique. And then I use cannulated Herbert screws, 2 mm in diameter. And as you can see, usually we use 2, minimum we use 2, and they are used to fix the fragment. This is post-operative picture of the same patient and the video of the same patient. I'm sorry it's not running, but he is now more than a year of follow-up. This is a video showing him to squat. Rehab is almost the same. We allow partial weight bearing, we allow gradual increase in range of motion, and obviously muscle strengthening exercises, quads, hamstrings. And then by 6 weeks, he is fully weight bearing without any external support, and usually allow him jogging after 3 months, 12 weeks, and then running after about 6 months. In young children, I would seriously consider screw removal with this technique. And thank you for your attention.
Thank you very much, Dr. Masood. So, very informative talk in the discussion of technique. We will move to our next speaker, Dr. Umer Butt. So, he doesn't need any introduction. So, Dr. Umer Butt has a very vast orthopedic sports medicine practice spanning over the 2 continents, so in Pakistan and UK. And he was maybe I can say the master brain behind arranging this webinar. So, Dr. Umer Butt.
Thank you very much, Naveed, for the lovely introduction. So I'll just skip all the slides. I just want to go straight to this slide, because we know one thing from the fact that a majority of the reconstruction is done on the basis of previous many years of evidence. But what if we saw a historic background and look into much more detailed factors, that why did we always felt that there is only one tool in the box, and that tool is anybody who has got an ACL injury would consider undergoing reconstruction. And today, this is the talk which I will take you through with some evidence, not only from us, but from international recognized center, and then show what is happening around the world in the last 5 years. Like Brother Masood said, that over 200,000 ACL injury in USA, and reconstruction is still considered a gold standard. Now, this is a Pakistani football player. I did reconstruction, and there is no doubt that it's an amazing procedure to do. But we also know from the fact that with reconstruction, there are many complications: revision, infection, unsatisfied patient, anterior knee pain, quads atrophy, and osteoarthritis. And it doesn't come without all this risk factor. But if you look at the historic fact, we know from the fact that the Mayor Robson performed the first ACL repair, and during the same time, Haygroves popularized reconstruction. In the early 1970s and 80s, repair was considered quite a substantial, important factor in fixing when there is a tear in the ACL. But during the same time, later in 1976, Fiagan and Curl understood that when the repair was done in the mid-substance tear, the failure rate was quite high. So what was the reason that this paradigm shift, a 2 procedure started in early 70s and 80s, one took the popularity and the other one didn't? So let's look at the historic fact.
In 1990s, several randomized controlled trials performed showing more superior result of reconstruction. Now let's look at this evolution of primary ACL repair through the prism of modern day understanding. It was not until 1991 when Sherman realized, when he looked at the literature search, that actually ACL tear was divided into 4 subtypes. Type 1 tear, which is the most proximal tear. Type 2, when the proximal tear is separated more than 30%. Type 3, mid-substance. And type 4, which is Professor Masood Umer just mentioned, tibial-sided avulsion. So he wanted to identify what was the tear type that led to higher failure and better success. Let's look at that. So when they looked at the literature search, they found out all the tear that was mid-substance and treated surgically with open repair had a very high failure rate. But at the same time, a published work from various authors who repaired the ACL tear from the proximal side showed much better result. If you look here, 75 patient, 42 and 51, the revision rate was almost 0% in some cases, and very few people needed revision and very high satisfaction rate. So what was the factor that played role in this paradigm shift from a repair to reconstruction? During the early 80s and 90s, Google and Embase were not very much familiar with the surgeons. The language was very difficult to understand, and primary ACL repair was called in some literature primary suturing of the ligament. The company put huge amount of input and research on arthroscopic ACL reconstruction and equipment. And obviously it became less popular to do an open procedure when it comes to comparison with arthroscopic procedure. But before all this, one thing we need to know, does the ACL has potential to heal? Why should we consider ACL to heal? Do we have an evidence to show that? So Sonnery, Cotat and Murray doesn't need any introduction. Published their work looking at the histological factor when ACL tissue damages. They took the sample, sent it to the lab, and look if there is any histological evidence that the ACL has vascularity. And they found well-vascularized synovial tissue, numerous fibroblast, myofibroblast, and mechanicoreceptor showing that the ACL tissue at the rupture end does have very high vascularity. We conducted the similar study, taking samples from various tissue from the ruptured end and comparing them from the proximal side and the tibial side. We also did partial comparison versus complete and acute versus chronic. And interestingly, our study showed significant higher value of synovial angiogenesis, ligament angiogenesis, and fibrocytes. But the most convincing fact about our study was that the remnant angiogenic potential significantly decreases 1 year after injury, making ACL stump to be very important stump for preservation or repair. Our study was published this year in the Knee Journal, and we also presented it into the ICRS and UK Biological Knee Society. So let's look at back to the future. So evolution of ACL repair and what are the methods available now? There are 4 techniques well recognized around the globe. One is the suture anchor technique. One is the bare bridge enhanced ACL repair, internal brace, and dynamic intraligament stabilization. I'll take you through this very quickly. The total number of publication work so far on suture anchor is 2, bare 1, internal brace 1, and DIS 6. So you can imagine we don't have huge amount of literature to suggest that this is the procedure that has been abundantly used all over the world. Gregor de Phillis was the first guy which made me believe that I should start doing repair. He's done the most work and published the most work, and his technique was suture anchor technique using swivel lock. And now he adds suture anchor with internal brace, taking the tissue with multiple suture and fixing it with the suture anchor technique. He has got the most number of published work in the literature so far. The bridge enhanced ACL repair technique is slightly different by Murray. You take a sponge of collagen, you attach it with the suture, you take a venous blood, infiltrate into the sponge, and fix it on the femoral side with an endo button or suture technique. Murray published the work in 2016. The first trial was ran in 2016, 10 patients selected. 2019, the published results show that at 2 years follow-up, similar result to ACL reconstruction, not a huge number. Internal brace, popularized by Gordon McKay from Scotland, 68 patient case series, and internal brace acts like a seat belt mechanism The company is Arthrex. They popularized this technique. And with the help of internal brace, you can suture it back onto the footprint, fix onto the femoral side with endo button and onto the tibial side with swivel lock anchor. The revision rate was 4% in his case series. The dynamic intra-ligament stabilization has been the most popular and most used in Europe. There is a dynamic ligament suspensory metallic button onto the tibial side, and on the femur side, there is an endo button. You fix it, and patient goes home and starts the physio rehab for 6 months. The issue with DIS is that you have to do 2 procedures. After 6 months, the patient has to come back and remove the screw. And that makes it a bit difficult in a younger patient. The result has shown by Egley and Hanley, the largest series on humans so far, over 300 patients. 3 to 5 years follow-up showed much higher failure rate, but the numbers were quite high, so we can appreciate that the number of 300 means that the failure rate was much higher in that. So when I started doing primary ACL repair, I had few things in my mind. And my concern was that the drilling tunnel should be very minimal. Removal of hardware should be easy. The revision should be much easier to do if it fails, and the cost. So I developed a single anchor technique, type 1 and type 2 tear, no tunnel, and easy to revise. And that was my approach. So I will take you through 4 minutes how I perform my primary ACL repair, and the video will demonstrate that. So this was a quite overweight guy in which we perform primary ACL repair, but I'll skip this video very quickly and show you the actual video of step-by-step primary ACL repair. So I always look at the MRI scan. Ideally, you need to have 1.5 Tesla scan. Now, if you can see, this guy has got proximal tear, type 1, I would say it, because if you have a good MRI scan, you will be able to plan your surgery well. Always have reconstruction on a standby. I use 3-portal technique. The central port plays a very important role, not only for suture management, but also for visualization. When you are putting a central port, it's very important to clear the fat pad, otherwise the instrumentation becomes really difficult. Once you have approached, use a probe or a trocar to examine the tissue thoroughly. I have simple instrumentation, suture cutter, suture passer, whatever you want to use, a drill guide, a drill bit, and a suture manipulator, and 2 sutures. So I want to keep it very simple, very easy, so that the surgery can be done without any difficulty. The first suture is a locking stitch from the central part. I like to take the most beefy part of the tissue. And then you run a Bunnell or a running suture. It's very important that you manage suture very well, and you should not cross the PCL tissue. Otherwise, you can take the suture through the PCL ligament. It's quite a nice playful surgery. You can use a probe to allow the loop to go to the most proximal part of the ACL, close to the footprint. And once the whole loop has been achieved to the most proximal part of the footprint, then I prepare my suture anchor. I use Stryker Relax anchor, which is 4.75 millimeter. And before that, I use a drill guide at 90 degree of flexion, aiming toward the Blumenset line or exactly onto the footprint area. Once the drill bit is done, you prepare your anchor. This anchor has got capability of bringing out 4 ends of the sutures on the right and on the left. And it also has got a tensioning effect to give double fixation. The suture management is very important. So you need to have a very good assistant who will manage your suture while you are inserting the anchor into the knee joint from the anteromedial portal. As you can see, I have inserted the anchor, and you over tension the suture. The graft is nice and tight. And once everything is fine, you start hammering it and insert the peak anchor into the footprint. It's a single anchor. If it fails, you can easily remove and convert that into a reconstruction. And as you can see now, the graft and the anchor is nicely tensioned, and the whole fixation has been done. So once that is done, you remove the loop and you tension it. Hamza, please. You tension it by twisting the black handle, and it brings the graft more proximal and tension it. Once this is done, you remove the suture, examine the knee that the anterior draw test is negative, feel with the help of probe that is nice and solid, cut the suture ends, take the knee from the range of movement, and as you can see, that the tension of the graft is really nice. I'll skip the video for the sake of time. And as you can see, with the help of the 3 probe, I want to see 24 months post-op result. The most important part is MRI scan. Have a look at the MRI scan. The MRI scan is showing well-contained tissue without any disruption. And this is repair been done. So we have done over 52 patients so far. No failure, 1 revision I have done recently. This is an old slide in which intraoperatively during surgery, the anchor did not felt very well. So I removed the anchor and I revised it to a reconstruction. I won't go into that. Masood already covered that. So I'll move to the next. These are the result. As you can see, the patient is very comfortable with the single leg hoop test. This is a 42-year-old guy in which I'm examining his knee after ACL repair. So in conclusion, preserve the nature, save the ACL. Thank you very much.
Thank you very much, Dr. Umer. So we are short of time, so we'll move to our next presenter, Dr. Yasir Khan. So Dr. Yasir Khan is the founder and CEO of YK Orthopedic Sports Medicine and Rehab Center in Karachi. So after graduating from King Edward Medical University in Lahore, he went on to study at the prestigious Royal College of Surgeons in Ireland. And in addition to this, he has gained valuable training and education from the United Kingdom, Germany, Russia, and Spain. And with over 20 years of experience in the field, Dr. Yasir Khan has worked as a consultant in orthopedic and trauma and sports in Ireland, Saudi Arabia, and Pakistan. So Dr. Yasir Khan will be talking about meniscal injuries with ACL. Dr. Yasir Khan.
Assalamu alaikum. Thank you very much. Good morning, good afternoon, and good evening, everyone. Thank you, Dr. Naveed, Dr. Masood Umer, and Dr. Umer Butt, brother, for your invitation. Nice talks all around, and I've been given the most difficult task to somehow save the meniscus while doing your ACL reconstruction. I have nothing to disclose, and so I have nothing to disclose. Let me start off by saying why you should save the meniscus. We all know about the anatomy of the meniscus. It is wedge-shaped, the blood supply is well established, and we know it performs a lot of important functions in the knee, like load transmission, shock absorption, joint stability, lubrication and nutrition, and proprioception. But the most important one is the load transmission. What it does is that it turns the axial load coming from femur onto tibia into a circumferential hoop stresses. So if you see, look at the picture on the right, you see the first picture where the meniscus is present and the load is evenly distributed. But when the meniscus is not there, the load increases tremendously onto the articular cartilage, causing the wear and tear and damage and leading to osteoarthritis. So this was published by Baloch in 1986, again, another biomechanical study. So if we do a partial meniscectomy, 65% of the weight is increased. And if you do a total meniscectomy, the transmission at the peak contact pressure increases almost 235%. And you can see it on your left with the truck, with a heavy body, with 2 tires. That's the weight is evenly distributed, there's less wear and tear with the tires, but if you remove 1 tire, the stress is more on a small surface area, and there's more stress and more wear. So which compartment takes more weight? The lateral compartment and the lateral meniscus, which carries almost 70% of the load in the lateral compartment, and that's because of the convexity that results in greater tendency towards peak loading. So it means that if you do a lateral meniscectomy, you end up with something like this. In 4 or 5 years down the line, the patient will start developing arthritis and the pain. So meniscal repair is not something new we are talking about today. It's been there and well established in 1980s by the father of the meniscal repair. We call him Dr. Charles. He invented and introduced the world to the inside-out technique, the perimeniscal abrasion techniques, and the fibrin clot. But unfortunately, meniscectomy is still the most commonly performed arthroscopic procedures globally. I don't know why. I'm guilty, maybe I'm one of them who used to do that as well. So what we have learned from from the historical perspective, this was the first study that came out in 1948, and they said that perhaps the meniscectomy can cause the ridge formation, narrowing of the joint line, and the flattening of the femoral condyle, but he couldn't really establish the link between the meniscectomy and the occurrence or happening of the arthritis. So what we needed is the long-term studies that could really establish the fact that the meniscectomy is harmful for the knee joint and its biomechanics. So we looked at this paper published in 2004. They did a follow-up, 21 years follow-up after meniscectomy, and they suggested that 71% of the knees did develop a mild, but alarmingly, 48% knees had more advanced arthritic changes. We looked at another paper, and this is published in 2016, almost 20 to 30 year follow-up. 3 out of 4 patients had developed radiographic tibiofemoral osteoarthritis, and 1 out of 4 had developed patellofemoral arthritis. So yes, now we have the reason. We know the meniscectomy can cause arthritis. The more problematic are the ones who are in their peak prime working years, like the age group between 30 and 45. And now, because we are more concentrated on preserving the meniscus, we have better investigation to identify those lesions, and we have better repairing techniques to preserve those. So the next question is, what can we say? We know the common types of the meniscus. We know the blood supply of the meniscus. We know there is a red zone, the red-white zone, and white zone. So anything that falls in the red zone is bound to heal. Red and white, we are still not sure, but we are hoping that it will heal. And white zone is still a dilemma for us. But having said that, we need to look at the incidence of meniscal tear with ACL injury. So we know ACL is a traumatic injury. Any tear of the ACL is a traumatic. So what percentage of the knees will have the meniscal tear? So this was the paper published 2015, almost 80% knees. More seen in patients who were left for more than 2 months. The incidence of meniscal tears were more, probably perhaps the wear and tear or the abrasion, and that may have caused it, not sure. So now we know that 80% of the knees with ACL tear will have meniscal tear. So where exactly it is? It's in the peripheral 1/3, more common in the peripheral 1/3. Good news, it means the peripheral 1/3 has a better blood supply, so we can save it. We should try and save those meniscus. Okay, so the next thing is, where is the located? Is it anterior or posterior? Anterior would be a lot easier, not required much of the learning curve, but unfortunately, the more meniscal tears associated with ACL injury lies posterior. So it means there's a steep learning curve, and you need to be careful, because when you're repairing those meniscus, you're very close to the neurovascular bundle, and there are reports suggesting the nerve injury and arterial injury with the meniscal repair. So you have to be careful. So with all this, we have the indications now. We can treat the acute tears, peripherally located, well-vascularized zones, and which are longitudinal, vertical in orientation. And we have extended our indication to the horizontal cleavage tears, the root tears, the ramp lesions, and the radial tears, and the tears in the red-white zone. However, we are still struggling with the tears in the avascular area. So if you're going into the OR and you're planning for a meniscal tear, you should be aware or well-versed with all the techniques. You should have all the armamentarium in your OR tray, so you can do, if possible, the inside out or the outside in, or all inside in techniques, whatever is available. And if there's nothing available, just remember, do not remove it, because removing will cause more problem. So if you remove it, what about the healing rate? This is the trial conducted by the Moon Group, which is the multi-center orthopedic outcome network. And they said that doesn't matter what kind of material you want to use, the healing rate is almost in the region of 95%, because remember, most of the tears are in the peripheral 1/3. So if they are in the peripheral 1/3, they are in the red zone. So no matter what you use, you will get it healed. We still have a problem though with the avascular tears in the avascular area, and that's what the future we're looking at. the orthobiologics, they're looking at the PRP augmentations, the bone marrow aspirates, and there's still trial going on for the PRP for the meniscal repair. The orthobiologists, maybe they'll have a role. Another thing they're looking at by the help of biomedical engineers, clinicians, and industry leaders to develop a meniscal implant. So that's everything is in pipeline. So hopefully in near future, we will have more things available to save the meniscus. So we have come a long way from the slogan raised by Smiley in 1967 to take it all out from saving the meniscus. Thank you.
Thank you very much, Dr. Yasir Khan. It's a very informative talk and very thorough. So we'll quickly move to our next talk. I'm ready, so I can join. I have a very quick talk, so obviously a little bit different topic than what we will be talking about, but it's a very quick talk. So this will be a brief talk, so I will go quickly. So management of ACL injuries in children and adolescents. But obviously it's a hot topic, so there are many controversial issues here. So no disclosures to made. So we don't, obviously it has been noted in the last 2 decades that the incidence has been rising due to various reasons. Obviously more children and adolescents are involved in sports activities happening more and more at a school level. So from 1994 to 2006, in 2 decades, in the US, the ambulatory procedures in patients less than 15 years old increased by 924-fold. It's a significant increase in the number. But there are important questions to answer when we are dealing with ACL in children. Most important are that do children who rupture their ACL mature similarly to their uninjured peers, and do they continue to sports, and do they prioritize their education and other interests over sport? And does an ACL injury and treatment change their lives? So these are very important questions. So we don't have any long-term thorough studies, rigorous studies performed. Obviously, most of the studies are done on adults, and which can give some input, some thought into the children. So mainly, just like most adult studies show that after 10 years of ACL injury, if it is untreated, people develop arthritis. So if a 10-year-old child develops ACL injury, so where he will be standing at 20 years of his age? So these are very important questions to answer. So how can the clinician prevent ACL injury in children? So role of prevention is very important. How does the clinician diagnose? So diagnostic test and imaging very important. And what are treatment options? So we will have a look on those. And what are the most important considerations when making treatment decisions? So skilled age assessment is very important. So there are different methods for that. Most commonly done is the PA view of the wrist, and then you can do the X-ray of the knee as well. You can do the riser grading. You can do the tenor staging. So that is very important question when you are dealing with that question. So the most important question which will assess, which will affect your decision making is the actual scheduled age of the child, and the factors to take the decision to construct or to go conservative, and then what are the children's role and responsibilities, clinicians, and then ethical consideration. Injury prevention is very important because of 2 reasons. One, obviously, the ACL injury has a very bad prognostic factors if it left untreated in children, and obviously because of their young age, they are prone to develop injury again, and also injury to the controlled limb. So prevention is even more important in children than adults. And we know there are compelling evidence that ACL injury prevention programs work in skeletal mature patients. So from that, we have inferred that they will work a similar way in the children as well. And there are some high quality injury prevention programs are the first line defense against the potential negative short and long term consequences of the ACL injury. They are straightforward programs, do not require much instrumentation or do not require much manpower, so they can be utilized at the children's educational or institutions or children's sports clubs, and even at home as well. So one well-established injury prevention program, the 11 plus, has recently been modified. It was for this program was for adult proposed by the FIFA and to suit the pediatric population. So how to diagnose? The history examination and clinical tests and imaging is the routine algorithm. So hemarthrosis, acute swelling in the knee within 24 hours after trauma due to intra-articular bleeding following acute knee injury is an important clue suggesting structural knee injury. So it has been estimated that almost 60% of the adolescents who present with acute hemostasis have ACL injury. So the incidence is very high. The suspicion should be very high when you see a child with hemostasis after trauma. And usually they are non-contact injuries, especially in female children. They are non-contact injuries due to various reasons, intrinsic and extrinsic. And due to immature skeleton, children may sustain different knee injuries, including the sleeve fracture of the patella and epiphyseal than adults. So you need to do X-rays first, epilateral tunnel and skyline view, as Dr. Masood has also described. So in children, tibial eminence fracture or avulsion is more common, maybe more common than the actual ACL rupture. MRI is obviously the gold standard. And if the child present with the locked knees, you should do acute MRI to see if it requires urgent intervention. So the issue is that the negative predictive value of clinical examination MRI for ACL, tear, and meniscal pathology are higher than the positive predictive value. So if the examination is normal and MRI is not suggesting tear, so it's likely the child does not have the tear. But in diagnosing, you might miss them if they show everything. I mean, if the examination is positive, MRI is showing something, it's not showing something, you may miss it. The goals, what are the treatment goals? To restore a stable, well-functioning knee that enables a healthy, active lifestyle across the lifespan, to reduce the impact of existing or the risk of future problems, which may be related with the instability of the knee, and to minimize the risk of growth arrest and femur and tibia deformity. Obviously, when we are talking about the surgical intervention. Treatment options are usually you can consider in two groups: high quality rehabilitation alone, which is the non-surgical treatment, and ACL reconstruction with high quality rehabilitation. You cannot separate high quality rehabilitation from the from the surgery. So both have to go and simultaneously, especially in kids. So without high quality rehabilitation, ACL surgery, how well it is done, may not prove fruitful, may not give that results, and vice versa. So what is high quality rehabilitation? Critical component, it is the critical component in the management of ACL injury. But obviously children are not small adults. The exercise program has to be tethered, or you can say based on their demand, their needs. Exercises and functional goals must be modified, not simply copied from the adult oriented rehabilitation protocol. And what is important is that the dynamic multi-joint neuromuscular control is the primary focus of ACL rehabilitation in children. So in young children, obviously with markedly open fascias less than 12 years, there is less emphasis on the development of muscular strength and hypertrophy. But in relatively older adolescents, where the growth potential is not much left, more than 14 or 15 years, so the same adult protocol can be followed. Emphasize exercises that facilitate dynamic lower limb alignment and biomechanically sound movement patterns, gradual progression to different phases. So rehabilitation phases are usually divided into 4 phases. I'm not going into the detail, but you can see for patients who want to choose surgery, there's a pre-rehabilitation phase. So you must have full active extension and at least 1 to 2 degrees of knee flexion, little or no fusion, ability to hold terminal knee extension during single leg standing. And for adolescents, almost 90% of limb symmetry on muscle strength test is compared to the opposite limb before you go for surgical intervention. So acute surgery is usually not recommended. So how to progress? Obviously, non-surgical treatment should last for at least 3 to 6 months. Postoperative rehab should last for at least 9 months or a year before return to full participation in preferred physical activities. The young athletes are at higher risk for second ACL injury following reconstruction. And obviously, the risk is more in first 12 months post-surgery. So what are the indications? So 3 most important indications: the child has repairable associated injuries that require surgery, that include the meniscal tear or tear of the other ligaments or any osteochondral defects or any fracture. So obviously, these are straightforward indications. When you go for repair or treatment of that injury, you should reconsider ACL as well. Or the child has a recurrent symptomatic knee giving away after completing high quality rehab, or the child experiences unacceptable participation restrictions. So obviously he has to modify a lifestyle which is not acceptable for his age. So again, you go for surgical intervention. What are the techniques? So these are general principles. Use a well-positioned soft tissue autograft of adequate size with adequate fixation to allow functional rehabilitation. Physical damage should be minimized to avoid growth disturbance, and bone plugs and fixation device should not cross the physis. There are different techniques. One is the transphysial, the physial sparing, and the partial, or you can say incomplete transphysial. So transphysial can be considered, it's just like adult, just like we do in adult. So it can be considered in older children who are tender stage more than 3 and skeletal age is more than 12 years, in girls and more than 30 years, in boys. And it is physial, transphysial, but you can say it is a physial respecting transphysial technique, a little bit modified from the adult. Single bundle cortical hamstring is usually used. Diameter of tunnel should be such that it should incorporate less than 9 millimeter graft, should not be a very large tunnel. So this is how it looks like. So the graft is obviously traversing through the physis. But why the femoral tunnel looks like this? So we will come to later on. So coming to physical sparing, so where you don't want to injure the physis, you have two different methods. One is the extra physical iliotibial vein autograft reconstruction. It is the old modified McIntosh technique. So you can consider in relatively younger children, less than 11 years old, and girls, and less than 12 years old and boys. Outcome has been reported in many literature. So there are excellent outcome with these techniques. The retear rate is 4.5% with 2.1% rate of osteofibrosis and 0.4% rate of septal arthritis, and no limb length and angular deformities has been reported with this technique. So this is how it looks like. So a central portion of the ITB is taken and then looped around posterior femur, and then under the meniscomeniscal ligament tied over the anterior cortex of the tibia. So it's the intra and extraarticular, both components are there. So another technique to spare the physis is the all epiphyseal technique. So you do not cross the physis, but you stay your fixation and your graft stays entirely into the epiphysis. So this is also a very good technique and routinely done now because of the development of more instruments like flip cutter. So people do this technique more often now, and the graft rupture rate is 4 to 17%, and MRI based investigation noted physical compromise in 15 to 20 tibia and 4% of 23 femora. So despite this technique is known as all epiphyseal, but there are problems with this as well. So if you are too close to the physis, this may damage physis, and there are reports which are showing physical compromise, but may not be showing too much limb length discrepancies. So this is how it is done. So all your graft is under the epiphysis, under the physis, in both in tibia and the femur. So, and then the technique is a partial transphyseal ACL reconstruction, where you can combine the extra-articular graft from the femur side to the articular graft from the tibia side. So how it is evident, and this can also be done in, you can say, children who are very close to maturity, where the tibial physis may not give much problem. What are the surgical principles and techniques to reduce the growth disturbance? So there are three main principles: drilling at the periphery of the physis and the perichondral ring increase the risk of growth disturbance. You should avoid that. Bone tunnel drill hole should be as vertical as possible and as central as possible, and do not cross the epiphysis with hardware, implants, or bone blocks. Fill bone tunnels with soft tissue rather than leaving the tunnels open. So this is a very important slide. So there are three different ways of making a tibial femoral tunnel. A is the transtibial, or you can see the more vertical tunnel. It is the old transtibial method, but maybe more preferable in the pediatric population. So this method versus B, which is the more anatomically oriented tunnel, but it's injuring more part of the physis. So animal studies have shown that if you injure more than 7% of the epiphysis, this may lead to growth disturbance. And then obviously tunnel C may not be very much anatomically oriented, but it preserves the physis as much as possible. Graft choice should be a soft tissue graft. You should not do a BTB in children to avoid damage to the patellar epiphysis. No allograft, because reports have shown that it's not, there are very high revision rates with allograft in children. There's a new technique of living donor allograft of the hamstring tendon. So maybe parent or something can be tried, but no long-term studies are there. And obviously you go for extracortical fixation, not the screws or something. Graft incorporation is very considered good because children are growing, they have a good healing potential. Adaptations and remodeling of the child, you have to consider in mind. The studies have shown the graft elongates as the child grows in the height, but it do not progresses in the diameter. So there's a double problem here. So on the one hand, to preserve the fasces, we want our graft to be to tunnel more vertical. But on the other hand, if the graft elongates further, and it's not increasing the diameter, this may even make it more vertical and cause instability as the child grows. Now the question, to operate or not to operate. So children who undergo ACL reconstruction after failed non-surgical management may have a higher number of meniscal and chondral injuries at the time of ACL reconstruction compared with those who undergo early ACL reconstruction. So this is also my observation as well. My population is usually adolescent, not very young children, 15 or 14, 16 years around, the couple of cases which I have done. And this is what I have noticed, who come late and who stay for non-operative treatment for a while, they show more meniscal and injuries, which was not evident in their earlier MRIs. The number of instability episodes prior to surgery appear to be a more important factor than the length of the time between injury and surgery. The non-surgical treatment is a viable and safe treatment option in skeletally immature patients who do not have associated injuries or problem. Abandoning non-surgical treatment in favor of ACL reconstruction is an option if the child has recurrent instability and obviously he has problems with daily activities. Now, what are the risks associated with ACL reconstruction? Important risks is the growth disturbance can be of three types: localized growth disturbance due to the fascial damage, or generalized growth disturbance due to the pressure, tight pressure of the tight graft, or it may be overgrowth due to hypervascularization sometimes. Second risk is ACL rupture, almost 13% rate of the same graft rupture, and contralateral ACL rupture 14%, because these are young children, very active population. And if you have more injuries to deal with, the poor long-term knee health is an issue. So knee stiffness is a problem which can be due to the injury, which can be due to the surgical intervention or inadequate rehabilitation. Infection rate is just like adults, 0.19%. So this is a quick algorithm. So if you are suspecting a child with a ACL injury, and go for MR to evaluate. If there is a partial tear and less than 50% is involving only AM bundle, grade 1 pivot shift, and he is less than 14 years of age, go conservative. If it is stable, he can progress to the full activity. If there is continuous stability or there is a complete ACL tear, then there is a different algorithm based on the age of the patient. So either you go for, in children who are close to skeletal maturity, go for fascial, just transphysial, just like adults, and who are away from skeletal maturity, less than 12 years or less than 11 years, try to go for fascial sparing, either all epiphyseal or extraphyseal, and then progress to full recovery in a year. So I hope this has covered the topic. So we are really short of time.
Naveed, if I interrupt in the middle, Julio wants to go for his meeting. So if we have one or two questions, he's happy to answer before he heads to the meeting.
Yeah, that would be nice.
Yeah, excuse me, guys. I have a meeting at starting at 8 here in Montreal for the mentorship committee meeting. So if you have any questions, otherwise I'll have to leave you guys. It's a wonderful, wonderful meeting. It's really, really exciting to see that going on. And I'm available for a short few minutes if you have questions.
So Julio, if I can begin the discussion, what would be your indication to take a fragment of bone along with patella as compared to a straight ligamentous graft?
Yeah, it depends on your technique. You know, I presented an all-inside technique where you have sockets. So you have a 15 millimeter socket on each side and a 30 millimeter interarticular length. So shorter grafts can be used for an all-inside. People that like an open tunnel on the tibia needs a longer graft. So you're going to go after 9 millimeter graft. So you cannot go any further proximal on your tendon. I mean, after 7 to 8 millimeters, you're no longer, getting the tendon, the quad tendon. So you have to add on the distal side, which is bone. So it's basically it. I mean, as far as soft tissue incorporation into the grafts, into the tunnels, I think there's this discussion. This has been going on and we have answered the questions already. So it goes well.
Julio, I have a question for you. So,
Sure.
for example, if we don't have the Arthrex cutting system, how many times have you done without the blade, like freehand opening up the incision?
Quite often, actually, quite often. If you look at the, I've seen some of the friends I have in Brazil doing that with just with a regular number 10. The thickness of number 10 and the depth of number 10 is just blade is just enough to cut through. And if you extend the knee, once you have taken the distal part and you have a clamp, if you extend the knee, you can bring the whole tendon almost out of the incision, and then you can just cut it with a scalpel or with a strong scissors. So you don't really need that cigarette cutting apparatus to get it done. The same way you don't need to have this sliding dynamic tightropes or whatever you call them. I was in Egypt in the beginning of the year, and there's this bright young orthopedic surgeon just showing me with a single button and with a sliding hangment knot. He was doing a dynamic button with cost pennies. So I think this kind of discussions we're having here are fun because we learn stuff. And actually, we should one day maybe present a webinar on the high-tech, low-cost approaches for our friends that need to do stuff without having access to $3,000 apparatus.
Just a quick question, Julio. Is there anything different in the rehab protocol from hamstrings to the quads you would do, or see something different, or you would do anything different?
No, because when you get the quad tendon, actually you're not dealing with the, if you compare it to the BTB, you don't have a risk of a high riding patella because you're not on a bone to bone approach. I mean this quad tendon is really giving a lot of room for physical therapy. So strengthening is as usual, and full weight bearing right away, full range of motion right away, and that's basically it. Compared to the BTB instead of the hamstrings, and then it's going to be all right.
I think we ask Julio how much time he has. We can continue discussion for next 1 hour, I think.
Yeah, I guess so.
Julio, we don't want to press you for time. I don't know how much time do you have? How long can you stay with us?
I still have 2 or 3 minutes, so a couple questions, and I have to leave for the.
Okay. Go ahead, Kazim.
Okay, I have a question, Mr. Fernandas. My question is that you have converted all of your ACL to quadricep, or there is specific indication where you go only for quadricep?
I like that question because actually I have to revise all my older OR cases into quad tendon approach. I mean, most of what I've done have become a quad tendon approach, and I'm not doing a hamstrings anymore, or just almost change that. But we can go into the discussion of what's your favorite graft. I mean, if you have a graft that's with a thickness of more than 8.5 and 9. With a good technique, probably the results are so much the same. So do what you're used to with the best technique available. Get a good graft, get a 9 millimeter thickness graft, and probably your results are going to be fun. And if you still feel uncomfortable, maybe the anterolateral ligament will help you out for these hyperlax cases. I mean, you're going to be discussing this, I'm sure. So preferred techniques are tough to discuss. So guys, I think I'll leave you then, and I'm sorry to leave you guys, but it's just like I have this problem with timing now. And
thank you.
Congratulations.
Thank you, Julio.
Wonderful panel. Wonderful meeting.
Thank you, Julio.
See you soon.
Thank you. See you.
You take care.
Especially on behalf of the Orthocon, I would like to especially thank you, Julio, and looking forward to welcoming you next year in winter. Hopefully, see you around physically at that time.
Absolutely. Salam alaikum.
Thank you very much.
Bye.
Bye-bye.
So,
we have last talk also.
Yeah, we will continue with our talk. So, Mr. Atif Malik has joined us. So, just a brief introduction. So, Mr. Atif Malik is a graduate of the, and he has taken his undergraduation from the University of Manchester Medical School. And then he went to the Royal National Orthopedic Hospital, Stanmore Higher Surgical Rotation for Trauma and Orthopedics. He has a number of fellowships in his portfolio. And currently, Dr. Atif Malik is a consultant trauma and orthopedic surgeon at the Milton Keynes University Hospital. So a very vast experience, very early career experience in sports medicine and knee surgery. So Dr. Atif Malik.
Hello. First of all, apologies for joining you guys a bit late. As you can see, I've just finished an ACL, so I've been trying to get through and make sure I got to the end of the meeting. Secondly, I'd like to thank you all for inviting me, especially Professor Umer Butt for his hard work for Pakistani orthopedics.
Not yet, Professor, just Umer Butt, I would say.
Well, if you're not, you should be. So I'm going to just talk about alignment correction when completing ACL reconstruction. So I'm going to go through the anatomy and the biomechanics very, very briefly. I'm sure that you all know all of this already, and it's been covered extensively with the talks that you've had today. So ACL is connective tissue, connects femur and the tibia, anteromedial posterolateral bundles, length of just about 3.5 centimeters, average width of about 7 to 12 millimeters. The native ACL has a tensile strength of 2,200 newtons. And obviously the biomechanics does change slightly according to the graft that you're using, either BPTB or the hamstring tendons, mainly type 1 collagen with a bit of type 3 collagen. So the knee, as you know, is like a round ball on a flat surface, and the meniscus is a crucial bit of that to try and support the knee and to try and give load sharing with very little support from the bones. The biomechanics of the ACL is complex. It provides both mechanical stability and proprioceptive feedback to the knee. In its main stabilizing role, it's a predominant restraint to anterior tibial displacement. It resists varus displacement in extension, and there's also some role in the control of rotation of the tibia on the femur in femoral extensions between 0 to 30 degrees. So what happens if you don't treat an ACL rupture? So this is a quote from David Dejour from Lyon. And his view is that if you don't treat an ACL rupture, you're likely to get osteophyte formation, superficial destruction of cartilage within about 10 years of the ACL rupture, with significant arthritis developing over a longer period of time. He estimates 20 to 30 years, and the additional meniscal lesion or a meniscectomy constitutes a turning point in the evolution of arthrosis. I think that's a really important point that he's making. So the meniscal factor is not the main factor, but it is a major contributory factor in the evolution of arthritis in the ACL deficient knee. You're planning your ACL reconstruction. You know that you're doing this to try and prevent arthritis in the future and try and give your patient a bit of stability. You never plan something with a view to fail. Your success always depends upon your previous preparation, and without such preparation, there is a high chance of failure. So you would never do an ACL reconstruction if you knew that it was going to fail. I hope everyone agrees with me on that point. So how can you plan your ACL reconstruction so that you give yourself and your patient every possible chance of success? And I'm just going to go through a bit about the alignment issues that you need to look at when planning your ACL reconstruction to give you the best possible chance of success. So there's quite a bit of literature to show that to prevent your graft from failing, it is important to look at the alignment of the knee. And that's not just the varus or valgus deformities, usually varus deformities in this scenario, but also your tibial slope. And both things are found to be quite crucial in preventing a failure of an ACL reconstruction. The main reason for this is due to the increased stress that is biomechanically being passed through the ACL. We'll go through a few literature papers, but there's lots, and you're welcome to do your own literature review as well. But there's 3 or 4 papers that I enjoyed reading, which I just want to share with you guys as well. So this is a paper from from a group out in America who looked at the role of high tibial osteotomy in ACL reconstruction with both a coronal and a sagittal plane deformities. And the evidence seems to suggest that an increase in the varus malalignment, together with an increase in your posterior tibial slope, increases the biomechanical stress that is seen in either a native or a reconstructed ACL graft. So the proposed argument is to correct both your sagittal and your coronal plane malalignments by employing a high tibial osteotomy, either prior to or at the time of ACL reconstruction, to correct these deformities and decrease the stress that's placed on the reconstructed ACL graft. The new way of thinking, so people were doing HTOs and then doing an ACL reconstruction as a second sitting. I think the group Ron Harden's group out in Holland has been leading the way in doing HTOs and doing your ACL reconstruction at the same time, and looking at the evidence, which I'll show you a bit later on in this talk. Actually doing these as a combined procedure seems to work well. So the use of a high tibial osteotomy for deformity correction creates a more stable knee and puts less stress on your ACL reconstruction, and has been shown to have good outcomes in regards to both postoperative pain, your stability, your satisfaction scores, and most importantly, function. So again, this is a paper that's actually just about coming into press. It's in the American Journal of Sports Medicine this month in December 2020, where both a combined varus correction and a slope correction led to a relevant decrease in your anterior tibial translation in the ACL deficient knee and an ACL reconstructed cadaveric knee. The outcome from this was that the ACL graft forces were significantly decreased after both a combined varus and slope correction. And thus the biomechanical findings support the treatment goal of a perpendicular aligned tibial plateau for ACL insufficiencies, especially in cases of revision surgery. So this is Laprad's paper. So again, his view is that the tibial slope and its effect on the anterior cruciate ligament graft increases linearly as the posterior slope increases. So the interesting thing when I found when reading through all this literature is that our concepts during training and during practice is that correct the varus alignment. And I think there's a lot more focus these days on not just the varus alignment, but also correcting the posterior tibial slope. And I think a lot of the literature that's coming out and a lot of the new evidence that's coming out is concentrating on the posterior tibial slope in conjunction with the varus malalignment. And I think that's something that I would want you to take home today. So again, in Laprad's paper, the tibial slope had a strong linear relationship to the amount of graft force that's experienced by an ACL graft in an axially loaded knee. So hypothesis being the flatter tibial slope had significantly less loading, whereas the steeper slopes increase your ACL graft loading. And this was a biomechanical study, which is supported by recent clinical evidence of graft failure with these posterior tibial slope being increased. So again, this is Leo's work from out in Australia. So he looked at 20-year outcomes of ACL with hamstring grafts and the catastrophic effect of age and posterior tibial slope. So his view is that repeat ACL injury after an isolated ACL reconstruction is much more common, especially so in the adolescents where you've got a posterior tibial slope of 12 degrees or more. And he found that that was the strongest predictor of repeat ACL injury. And again, the negative effect on was more pronounced in the adolescent group rather than the adult group. So what are our goals? Our goals are that after our successful osteotomy, which is something that we've just decided that with our malalignment, either varus malalignment, tibial malalignment, tibial slope malalignment, or both, we want to have an ACL reconstruction which lasts. And as I said, this can either be concurrent at the time of the osteotomy or as a second stage operation. Although the process and be quite painful, by completing the osteotomy, it gives the patient the best possible chance for a successful ACL reconstruction. So what are the principles? So we're all familiar with our mechanical access. So again, for some of the junior trainees who might be listening, the mechanical access is a line that's drawn from the center of the hip down to the center of the ankle mortise, usually a nice straight line. The anatomical axis, which is your tibiofemoral angle, is a line which is drawn through the intersection of the shaft of both the femur and the tibia. And normally, the difference between these two is about 5 to 7 degrees, depending on patient height. Again, where the mechanical axis is determines the percentage of load that's carried in each department. In the normal knee, 60% of the weight bearing is through the medial compartment, as you can see on that top picture. That's without your mechanical axis and the anatomical axis intersecting at 5 to 7 degrees. If, however, there's malalignment, the load bearing is changed. And as you can see, if your mechanical axis and your anatomical axis intersect at 0, then your medial side takes 80% of your weight. And again, if it's more on the lateral side, then it's the opposite way around. And this imbalance is exacerbated so that a deviation of 1 degree from the varus, from the neutral alignment, increases the medial load by 5%, which is obviously can add up quite significantly. What types of different osteotomies are there? There's the medial compartment OA with varus deformity, which is a valgus producing osteotomy. There's the lateral compartment OA with valgus deformity, which is a varus producing osteotomy. Then obviously you've got your alterations in your tibial slopes, which can be done for ACL deficient or PCL deficient knees, depending on the type of lesion that you're trying to correct and the type of ligament reconstruction that you're trying to do. I'm going to concentrate mainly on the medial compartment changes with the varus malalignment, and also talking a bit about the tibial slopes as per our initial guideline. So the different techniques. The lateral closing wedge, which is where a wedge of bone is removed from the tibia, or the medial opening wedge, which is where a bone cut is made in the proximal tibia and wedged open on the medial side. The advantage of this is that it maintains the posterior slope. It can cause a bit of patella baja by raising your tibiofemoral line. However, as long as you're aware of that can, and you can take steps to make sure that that doesn't happen, it's usually a fairly straightforward technique. There are also focal dome osteotomies, with the concavity being more proximal and centered along the chora. We're going to mainly be talking about the medial opening wedge, because that's, in my experience, is the most traditional and the best use with the most predictable outcomes. So the recent studies have shown that the opening wedge HTO has several advantages over the closing wedge HTOs, including higher accuracy of correction, better survival at 10 years, wider range of motion, less soft tissue dissection, and more reserve of the proximal tibiofibular joint. Again, all reasons to do the opening wedge rather than the closing wedge. So the surgical techniques. So the technique that I would suggest and which I have used is the biplanar opening wedge HTO, which is where your osteotomy is carried out in 2 different planes. As you can see from that picture, the opening, so your incision is midway between the anterior tibial tuberosity and the posteromedial border of the tibia. Horizontal cut is similar to your standard opening wedge HTO. However, your second cut, which is a vertical part of the osteotomy, runs posterior to the anterior tibial tubercle. And using fluoroscopic control, 2.4 K wire is aimed towards the head of the fibula. This is before you've done your osteotomy. The guide wire is just there to guide your cut. The sagittal cut is performed in the posterior 2/3 of the tibia, with the osteotomy being 1 to 2 centimeters parallel to the, medial to the lateral tibial cortex. You're not going all the way through to the lateral tibial cortex. You want a bit of a hinge, and therefore your osteotomy is only going 1 to 2 centimeters medial to this. You then make your second cut, which is more in a vertical alignment in the coronal plane, and this allows your tibial tuberosity to stay with the proximal segment of the tibia. I hope that is easily visible on the pictures that I've put down there. So you've made both your cuts, you've made your biplanar cut, then you want to put a wedge. Now, I've not put this in here, but I would strongly suggest that if you're doing this, you would use some form of templating software. The software that I use is called TraumaCAD, which is absolutely fantastic in terms of being able to predict exactly what sort of gap that you need to open. What you don't want to do is overcorrect either. Using this trapezoidal metal wedge decreases the risk of altering your tibial slope and increasing your tibial slope, which, as we've said before, is something we don't want to do. Likewise, if you do want to alter your tibial slope, this is the stage, and this is the bit of the operation that you can alter your tibial slope to try and correct any tibial slope malalignment. Once you've got your osteotomy made, you've opened it up to the point that your templating software has guided you preoperatively. The plate is then applied. Bone graft as per choice. A lot of people, and there's lots of evidence out there that if you don't put any bone graft, the bone still heals. It fills in quite nicely, but you're quite welcome to use any bone graft and it will still heal. I find very few of these have a problem with bone healing. Next slide, please. So once your biplanar osteotomy is complete, you can then proceed with your ACL reconstruction. And as I said, this can either be done with the same anesthetic, same incisions, or if you are more comfortable and want the swelling to settle down and get a bit of rehab going, then you can do that at a later time. The advantage of doing it in the same sitting is outcomes are good. We'll come on to that in the next slide in a second, but also your incisions are pretty much the same. So you can actually use your medial incision for your tibial tunnels, and it works quite nicely. So the outcomes, the combination of a HTO with an ACL reconstruction produces good results, and the resumption of normal daily activities as well as recreational sports. It doesn't seem to increase the risk of complications compared with isolated HTOs. Again, this is a paper from 2017 by Rossi and his group, but there's lots of papers coming out which are saying very similar things. So the conclusion, combined HTO with ACL reconstruction is a safe and effective procedure with good outcomes, including good outcome scores and activity levels. It improves alignment, it improves the stability of your reconstruction. It reduces the risk of graft failure. It reduces the risk of developing osteoarthritis. So that is the end of my presentation. I welcome any questions. I gather since I'm the last person, all the questions have been saved till the end anyway. Apologies if I rushed through the end of that. I was getting messages from the moderators to tell me to speed up because we were overrunning.
Saad, are there any questions from the audience?
Yeah. No, thank you very much, Dr. Malik. So there are questions. I mean, are you able to read the chat by yourself, Mr. Malik? So.
There is a question also.
I read just one question for Atif. The question has been asked by Fahad Hussain. Atif, are we advocating osteotomies for all primary ACL injuries for correction of coronal alignment in addition to sagittal alignment? Question by Fahad Hussain to Atif.
So no, I don't advocate you do an osteotomy in every single ACL reconstruction. What I'm advocating is that if there's a malalignment, then there is evidence and literature out there to say that if you don't correct your malalignment either in the coronal plane or the sagittal plane, then that increases the risk of your graft failure. So you obviously have to do very careful assessment beforehand and identify, is there any varus malalignment? Is there any increase in your tibial slope? So that Leo Pincheski paper showed that if you have a posterior tibial slope of more than 12 degrees, then it has an almost catastrophic effect on your graft and the risk of it failing. And obviously, if you're doing a reconstruction, you want to give your graft every possible chance of success. Patients from the subcontinent and the Middle East generally have varus alignment, and it's generally understood that high-level athletes with varus alignment are unlikely to cope with varus correction to less varus valgus. Should we be correcting them in the context of ACL injury? That's a very good question. As far as I'm aware, I've not seen any evidence or literature in elite athletes to suggest that if they have an ACL reconstruction without the varus malalignment being corrected, what that does to their graft. I think looking at the literature out there, there's probably a balance. So if it's a balance between an increased risk of failure and the not coping with a less varus, as you suggest. And I think you just have to take each patient and have that conversation with each patient individually and come up with a personalized plan for every single patient. And with my experience of elite athletes, you'll find that they often come with a view themselves on how they want things to be done.
So there is a question again. Fahad has asked, how much posterior slope can be accepted? So if you don't mind, I'll just chip in. So Fahad, a nice question. The answer to that is Leo Paczynski paper. 12 degree, less than 12 degree is acceptable. Over 12 degree, you have to do posterior tibial slope correction.
I completely agree with that. Young person neglected combined ACL and PCL injury and chronic posterior subluxation of tibia for 9 months, along with 15 degrees fixed flexion deformity. What additional interventions would be helpful before proceeding for ligament reconstruction, and what considerations will be required for a successful outcome? It's a fairly extensive case. So again, in the context of this presentation, your alignment, but also what I find is neglected posterolateral corner injuries so in this scenario, if you've got an ACL, PCL with a chronic posterior subluxation, I would be very careful, and I would do a very careful examination of your posterolateral corner. If you do your ACL reconstruction and you've neglected your posterolateral corner, it will fail. So, you know, it's not just the malalignment, bony malalignment, but it's also just making a very careful clinical assessment and identifying if there's any other ligament injury which require. So Umer's answered the second question as the posterior slope can we accept.
I think this is Atif. I think this is the question by Professor Umer Masood. So, Prof. Umer Masood, can you please answer how can we open by which approach in ACL tibial spine avulsion, minimal or open? Question to Professor Umer Masood.
So I've never opened till date any tibial spine avulsion. Can be reduced close, and as I said, in my experience, I've done chronic avulsions also, and they are amenable to close reduction as long as you clear the fibrous tissue out from the crater. Essentially never required to open.
Excellent.
Can be done through a scope.
So I think in the beginning of the conversation, there were a few questions by Fahad Hussain. He said that the most recent literature suggests that the failure rate of ACL repair is 50%. And then the second question he asked, is there something that we should be doing different in terms of indication? And the similar question he asked me that what if I am in Pakistan? That is for Munawar Shah. I answered him. So let me just answer the first question for Fahad Hussain. Just to let you know, guys, we all need to understand one thing that like Kazim and all my colleagues have just mentioned, there are debates going on and evolution going on in soft tissue reconstruction. 10 years ago, if we talked about ALL, nobody even knew it. Now it is considered the hot topic of the subject. 10 years ago, if Atif Malik was sitting here doing training, he would have never even talked about osteotomy in this depth, apart from saying that, yes, we can do osteotomy and leave the patient alone. 10 years ago, if we talked about meniscal repair, or 15 years ago, we would have said in Pakistan, there is no chance we can ever do meniscal repair. Now, every big center is doing meniscal repair and ACL reconstruction and tibial spine avulsion. We are all going through an evolutionary phase. As I shown in the literature, and I mentioned to you before, 12 systematic review has been published in the last 12 months. CCOT made the biggest primary ACL repair webinar last month, which I was doing. There is a hot topic in town. We still are at the evolutionary phase. We are still learning about it, but definitely one thing is for sure, that saving the knee joint will be the future, either by orthobiologics, either by repairing it, either by minimal reconstruction, adding biology to it. So we cannot just justify by simply saying 50% failure, because there is no literature to so far shown anywhere 50% failure of ACL repair if you have done it in a right selective group. That's the reason 12 systematic review has been published. I have been doing ACL repair for the last 2.5 years, and I didn't had more than one failure. The reason being that I haven't done a lot. If I do 200 plus ACL reconstruction, I only do 15 to 20 repairs. So you can imagine the quantity of repair is much smaller. Your indication is much small. So if you have choose rightly the patient, you select them well, under 6 months, good tissue quality, the results are great. But as for anything, even reconstruction has failure. All my colleagues will agree that our ACL reconstruction fails. So it doesn't mean we stop doing them. Similarly, ACL repair will fail, but we will always have a backup plan to do a revision and do a reconstruction. But if reconstruction fails, then doing a revision is a big job.
Yeah, so I think if we have no further questions, we are already 40 minutes past the dedicated time. So we should thank you very much. Thank you all the faculty, Dr. Umer, Dr. Mr. Malik, Dr. Yasir Khan, Dr. Kazim, and Professor Fernandas left us earlier because he had a meeting. It was a really wonderful webinar. I think we tried to cover all the different topics which are not usually covered in talks on ACL, and nicely covered by all faculty. So any further comments from any faculty are welcome. Then we should end the webinar today.
Yeah,
well done,
great
Masood
event.
Umer.
Yeah, boss, big brother.
And excellent present. I agree first time with Umer Butt as well. Normally I don't agree with him, but it is evolution and we must go for it. And like all of us who are a wee bit older regarding ACL reconstruction, we all went through a learning curve, a big learning curve. And likewise, the same thing is happening now. And thanks to Umer Butt, one of my colleagues is doing it as well, and I keep on giving out to him. But good results with few cases. But again, it will take a while.
Yeah. Thank you, sir. Thank you very much. I think in the interest of time, we close for now. We are consistently losing participants. I hope it was useful. We'll continue next Saturday. We have a webinar on vitamin D metabolism and the myths associated with vitamin D deficiency and its treatment.
Thank you very much. Thank you, everyone.
Have a good weekend.
Allah Hafiz.
Thank you very
Bye.
much. Allah
Allah Hafiz.
Allah Hafiz.